Okay, this is chapter 64 for musculoskeletal problems. And we're going to start off with bone infection. So osteomyelitis is a bone infection. It can be usually caused by staph. It can be caused from a direct or indirect route, and it can be acute or chronic. So a direct route is where we've had some type of trauma or foreign body or open wound go directly into the bone. With direct trauma, we are going to have ischium, which of course is blood loss, which creates cell death. When you have bone death, you have going to have sequestra, which I always think of, horses when I hear that. But sequestra is a purulent pus inside of the bone. Purulent, I can't say that word. Inside of the bone, and either it's going to have to be, we're going to have to actually remove a debridement, or it's going to start leaking out into and push out through the skin. The problem with this, of course, is that it can spread to other places, and it's creating cell death, which is obviously not good. The purulent can just ooze out of the body, or it can stay in there. Either way, you're having significant issues with the bones themselves. Now that's direct. In indirect, that's caused, and oddly enough, they associate it with blunt trauma, often seen in young boys who roughhouse play around. So boys under 12 often experience a lot of blunt trauma, and that could cause a indirect route for osteomyelitis. So blunt trauma, vascular disorders. So vascular disorders are also can be attributed. So if you have a vascular disorder, it could spread to the bones. And in saying that, some of our more vascular bones are going to be your tibia, your pelvis, and your vertebrae. So those are your vascular rich sites, and if those sites become infected, then it becomes indirect osteomyelitis. All right, now it can be acute or chronic, and of course acute is going to be shorter. The acute osteomyelitis is an initial infection. It usually lasts 1 month or less, and it can have local and systemic manifestations. So your local are going to be what you would assume they would be: swelling, tenderness, warmth of the site, tingling, numbness, things of that nature. And then your local are going to be your systemic is going to be your fevers, your chills, your night sweats, your nausea. Those are always going to be your systemic type of manifestations. Your chronic osteomyelitis, of course, chronic means longer, is a bone infection lasting more than 1 month. It generally doesn't respond to the first course of antibiotics, and you're going to need MRI or X-ray. You can identify those. You can also do blood work and identify microorganisms that might be in there. Of course, elevated white blood cell count is going to make sense. The problem with this is that it has the possibility to really disrupt vital organs. And if possible, when you have a chronic event, you really want to try and get a biopsy, because obviously that first round of antibiotics didn't work for a reason. So if you can identify what's causing it, then a lot of times we can treat it better. However, you don't want to wait around and treat it. So if it becomes where they absolutely have no idea what it is, they're going to give you some type of antibiotics. And the antibiotics for chronic osteomyelitis are going to last a long time. It can go from 4 to 6 weeks to like 6 months, which is going to create other issues. When we're on antibiotics that long, we're killing off our good immune systems, the good bacteria in our body as well, which is of course going to give you yeast infections and put you at risk for C. diff. Obviously, it says IV antibiotics, like I just said. The immune compromised people are obviously at risk. But your health promotion factors are, again, identify those who are immune compromised, treat infections and control infections the best you can, because you have a vascular infection today that becomes an acute osteomyelitis, and then all of a sudden you have a chronic osteomyelitis with MRSA because you've been taking antibiotics for the last 6 months. So control of the infections that are already in your body, and really watching out for those immune compromised people is going to be important when you're treating chronic osteomyelitis. All right, tumors. Tumors can, of course, be either benign or malignant. And I'm not going to get too much into this other than usually you're going to have surgical removal. Obviously, you can identify these through MRIs, CTs, things like that. But you're going to have, with a benign bone tumor, You really want to watch it, make sure it's not causing any nerve or neurovascular issues, like i.e. pressing on a nerve, cutting off circulation, things of that nature, and making sure that doesn't become malignant. The way that I'm gonna, so for benign, you have osteo, and of course osteo means bone, and I've got to refer to something to be able to spell it. Alright, and really paying attention to these suffixes here is going to help. And osteoclastome is going to be the other one, and endochrome. Alright, so your endings for your benign tumors are going to end in ROMA. So benign are going to end in ROMA. Your other one is going to be TOMA. Alright, so osteo, and then those suffixes are going to help identify benign tumors. Now malignant, the malignant is the same thing. You're going to be looking for that suffix again to help identify it. And those are osteosarcoma, osteosarcoma, but you're looking for this suffix right here. So osteo, and then be looking for this suffix right here. When we're talking about malignant, of course, malignant is cancerous, and we want to make sure that we're treating that with surgery, radiation, and that it's not metastasizing to other areas. And of course, when we're talking about bones, that's bad. So we really need to be looking at that. There are several different types of benign and malignant tumors, which I won't go into. But if you can identify those suffixes, it will help out. Muscular dystrophy is just the weakness, loss of muscle. So it's a progressive wasting of muscle mass, or skeletal muscle specifically. There's not really anything we can do about this, but the best thing we can do is try and extend the use of the muscles, so ensuring activity, providing physical therapy and exercise, things of that nature is going to be what we're looking for. You really need to watch out for the muscular dystrophy for your cardiac incidences, dysrhythmias, things of that nature, because that's usually where the mortality rate comes in. Dysrhythmias, cardiac, period. Obviously, our heart is a muscle, so we need to watch out for that. The lower back pain. Lower back pain affects a lot of people. You're talking about 80% plus that it affects. And of course, there's different types of pain, which you go into in chapter 9. But the for lower back pain, it's defined by either it's localized, so if I palpate it, it's going to cause pain. It's either diffused over a larger area. It also can be radiating or radiopathic, which means that it starts in my back and maybe ends in my feet or ends in my glutes, or it's radiating, and it's radiating because I've agitated a nerve at that point. So anytime we're talking about radiating pain, we're talking about we've agitated something. You also have referred pain, where it, for instance, like the kidney infection hurts in your lower back. So you could have pain in your chest, but it relates to your back. So that's referred pain. So again, localized, I palpate, it hurts, diffused over a larger area, radiating, I've hit a nerve and it's traveling down somewhere, lovely. And a referred pain, where it's a completely different area. And that's for lower back pain. Now, for lower back pain, like I said, it affects a lot of people, 80% of people, in fact. It's caused by stress, poor posture, poor body mechanics, excess weight, lack of exercise, and the smoking, of course, is never great. So smoking is another risk factor. Your acute low back pain is less than 4 weeks, and I'm laughing right now because this is less than 4 weeks, and this is 3 months or more. Again, not sure what happens in between those. Maybe acute chronic, I don't know. But anyways, so acute is supposed to last less than 4 weeks, and it's usually caused by trauma, obviously. You can use, a lot of times when we have an acute low back pain, we're not going to use MRI or CT. And I'm just going to let that up there because I would have thought to use it. So they're not going to use MRI or CT unless they suspect systemic injury or there's a trauma and we need to make sure that everything's good and functional. Instead, they're going to use that straight leg raise, where you're raising your leg to 60 degrees and you're having that foot flex. to identify acute lower back pain. Of course, your health promotion and Healthy People is going to recommend pretty much the same thing. Your Healthy People 2020 is recommending weight loss. Not sleeping in the prone position, which really puts a lot of pressure on your lower back. Making sure that you have padding for your pillows in between your legs and underneath your legs if you're sleeping on your back, and in between your knees if you're sleeping on your side. And that will be the same treatment that you use for patients with spinal surgery. Also, avoiding smoking and, of course, proper body mechanics. Your patient teaching is going to be, again, very similar to your 2020. All right, you've got sleeping position, physical therapy, or physical exercise, whatever is tolerated best. Of course, patient specific. Make sure that you hold the items close to your body. So if I'm carrying something large or heavy, I'm going to hold it close to my body. Using heat and cold, and again, you use cold for the first 24 hours, and then you alternate heat and cold after that. And your lumbar roll. The lumbar roll, first of all, when you're talking about a log roll, we're talking about moving somebody in complete unison when they have a spinal injury. Now, there's braces that you can use that can help immobilize your trunk, and you would use a log roll technique to put on some of those braces as well. All right. Make sure you're bending at the knees, not lifting above the eyebrows, and standing for too long can create issues. So shifting your weight, kind of like those lizards as they walk over the desert. Do this. Anyways, it's kind of cool. So brief rest, no bed rest. Bed rest is going to create bigger issues that you have to deal with. So limited activity, but not bed rest. Okay, bed rest is not going to help you. Chronic low back pain. Chronic low back pain, like I said, lasts more than 3 months, and it can be caused by degenerative disc disease, osteoporosis, or some type of other bone disease. So if you have another type of bone disease, this is where you have chronic lower back pain. Spinal stenosis is, and I didn't get that up there, but spinal stenosis is the narrowing. Of course, this is going to cause back pain too, but spinal stenosis is the narrowing of the spinal canal itself. And when we have the narrowing of the spinal canal, it's a lot of times caused by bone spurs, calcification of the area, like it shouldn't have excess buildup, and all of a sudden it's starting to close in on itself. Or compression. Paget's disease. Paget's disease is your bones are just randomly going wherever they want to. That's an immune issue usually. And then tumors and rheumatoid arthritis. So those are causes of spinal stenosis, and again, that's a narrowing of the spinal column itself. With spinal stenosis, your pain usually starts in your legs and radiates to your butt and back, or glutes and back. That would be referred pain. It's actually radiopathic and kind of referred pain. But anyways, so that is spinal stenosis. Chronic back pain. So the treatment for chronic back pain, and I didn't write that up there, but treatment for chronic back pain is going to be making sure mild analgesics, NSAIDs as appropriate, and anti-seizure medicines to help with gait and mobility. Weight reduction obviously is going to be helpful. Making sure they're getting plenty of exercise, and of course, if they're having some issue related to the calcium and phosphorus, make sure you correct that as well. The cold and damp actually does aggravate this, and that has to do with pressure, or atmospheric pressure. All right, intravertebral disc disease. Intravertebral disc disease is basically where the discs themselves, and again, just to remind us, we have our body on the screen. Yeah, we have our body, and then we have a spine. So we have in between each vertebrae, we have a disc. A disc is usually made out of fibrous cartilage that is a little bit more absorbent, and it helps with shock. And again, there's a lot of our back takes a lot of the blood of our weight and our body movements. And again, I'm eating cereal at 7. I'm having tea at 12, and lasagna at 5. So that will help you remember. C7 to T, and then of course you have your sacral. But that's how I remember that. The intravertebral disc disease, again, discs are slipping out in between. Now it can come in your herniated disc. It's going to be where you have a lot of pressure to smash down that disc. or you've had a deterioration of the disc, which like degenerative disc disease, where it's smashed down and it's starting to slip that disc out. So the herniation or diffusion of the disc, degenerative disc disease is so with degenerative disc disease, there's a thinning of the disc nucleus. Basically, the nucleus of the disc has this gelatinous center. All right, this nucleus is gelatinous, and it's nucleus pulpus. So this is your nucleus. Oh, make sure I'm spelling that right. Alright, it's starting to dry up, and that's your gelatinous center, so it's starting to dry up, and of course when it dries up it shrinks, and when it shrinks it cannot withstand as much pressure, so that transfers the pressure on the outside of your disc itself, and naturally the outside of your disc is not meant to take that impact, and so the fibers outside your I'm going to write this out because Lord knows I can barely, annulus fibrosis. That's the outside of your disc, is going to start to deteriorate because it's not used to or made for handling that much weight. Herniated discs, again, are slip discs, and generally they will occur in your L4 to L5. They will also occur at L5 to S1, which we have to take down here. I'll have to think of S. Maybe something sweet for dinner. I don't know. So L5 and S1, and then C5 through 6, and C6 through 7. So I'm talking about in between these discs, okay? Degenerative disc disease can be caused by aging, stress, trauma, spinal stenosis. Again, that's an area of the common. You can have radiopathic pain, which that radiopathic pain is, again, radiating pain of agitated nerve, and it's shooting all the way down my leg. And kind of like when you're pregnant and you have that nerve that hits, and it'll knock people to their knees a lot of times. Anyway, it's going to have tingling and loss of range of motion because it's neuropathic. Osteoarthritis is also associated. So that's not the color I wanted, but that's okay. Yes. Osteoarthritis is also related to your degenerative disc disease. All right, lumbar disc disease, that's lower back pain. It radiates down to through the buttocks and below the knee. Excuse me. They use straight leg raise to help identify that, and you're going to experience depressed reflexes, multiple nerve root, and I think I'll use a different color for that. So with your lumbar disc disease, lumbar disc disease, that's of course going to be in your lower part of your lumbar, or your back, I mean. And it's going to radiate pain down through your buttocks and through your knee. You use that straight leg raise there. And you really want to watch for incontinence. Incontinence, a sign of incontinence. If you have pressed down or prohibited a bunch of nerves from working, or depressed the nerves from working, then you can have bowel and bladder incontinence, and that is a medical emergency. All right, so medical emergency is incontinence here. All right, so medical emergency is incontinence, and it can also be caused by a herniated disc or tumor. But multiple nerve root depression is going to relate to this incontinence, and again, that's a medical emergency. All right. So osteoporosis. Let's get rid of this one. Oh, neck pain. I skipped one. I apologize. All right. So for neck pain occurs for about 50% of people. The cause is it can be related to a growth in the spinal cord. It can be poor posture, strain, or sprain. So if I sit there with my head down, I don't know, looking at textbooks for the next 12 hours, my neck might hurt. It can also be caused from trauma, strains or sprains, and again, remember strains and sprains from before. A strain is I've strained my muscles, larger muscle group, and a sprain is where I've injured the ligament itself and potentially ripped something. It can be caused by neck pain. Can be also caused by degenerative disc disease. So neck pain can relate to degenerative disc disease. And of course, if you fractured your neck, that's going to create a problem. Spondylosis, rheumatoid arthritis, tumor osteoporosis, or meningitis. Meningitis. I'm gonna write that one up there. Meningitis. All right. So if meningitis has gone into your spine, patient teaching for this. Basically, it's gonna tell you to exercise your neck, which is funny. But anyway, exercise your neck. They want you to go in every range of motion that you can 5 times slowly. Okay, so that's here, 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 and then around. And I've always been told not to do this, but that's okay. So that is how you're going to exercise the neck, and that's part of your patient teaching. Osteomalacia, that's a vitamin D deficiency. So osteomalacia is a vitamin D deficiency. And again, we don't see that very much, but it's related to rickets in children. It's the same thing as it is in adults. Vitamin D, obviously, you get vitamin D from going outside. So if you have some type of thing where you're not going outside, or extensive burns, GI issues, there's a couple of other ones. Fentanyl. Fentanyl, or otherwise aka Dilantin, will cause vitamin D deficiencies, and morbidly obese. And I actually didn't think about that one, but morbidly obese. And this is going to cause a softening in the bone. So without vitamin D, we cannot get calcium in, and without that, obviously, calcium phosphate is what our bones are made out of. So without that mineral in there, our bones begin to soften. Naturally, you're going to eventually break, or sustain some type of break. So if the non-traumatic fractures, the patho fractures, those can be in osteomalacia, obviously in osteoporosis, which we're going to talk about in a second. All right, osteomalacia manifests itself in bone pain, muscle weakness, and specifically muscle weakness in the pelvic girdle itself. So a lot of times you could see incontinence x-rays. You're going to obviously have low calcium, low phosphate, vitamin D deficiencies, and they specifically named D2 and D3. D3 being a little bit more absorbent, but they specifically named D2 and D3 as being important. Osteoporosis is a porous bone. It's a metabolic bone disease. So not to confuse osteoporosis with osteomyelitis, which I often do. Osteoporosis is porous bone. It's a metabolic bone disease and low bone mass. In women, and this is crazy, 1 in 2 women will experience a fracture related to osteoporosis. That's pretty crazy. 1 in 4 men will experience it, and of course that's our older population, plus 50 plus, have some type of fracture from osteoporosis. So the reason why women are at more risk, and they are 8 times more risk than men, is because they have start off with lower bone mass. They take in less calcium. We also have menopause, pregnancy, and their bone reabsorption sooner. The other problem that we're seeing is longevity. So as people live longer, we have more issues. So they recommend that women have a bone scan before 65 for osteoporosis, and men at 70, and that's again because they're at less risk. There is health disparities here. I'm going to hit on in a second. If you're at risk, or you've been identified as being at risk, then you're doing it every 50. If it's okay, if you go do this bone scan at 65, you don't have to do it again until you're 80, every 15 years if it's normal. Bone scans are measured in T, also Z, but let me put my notes on that page, which is somewhere. Osteoporosis, all right. Oh, your risk for osteoporosis. If you're 65 plus, a female, low body weight, and you're getting your health disparities here. If you're white, or Asian, you're more at risk. African American, Native Americans, and Hispanics are less at risk. Smoking is going to put you at risk. Non-traumatic fracture, that patho fracture, basically caused by nothing at all. You're standing there, your finger breaks because you have osteoporosis, and because all of your compact bones pretty much become spongy bones. And I say spongy bone like this because it's not actual spongy bones. It's just horrible. A horrible matrix of bones. sedentary lifestyle and postmenopausal, so after menopause. Family history of osteoporosis, a diet low in calcium, and that's the other thing, women eat less calcium early in life than men do. So a diet low in calcium and vitamin D, and again, it names off D3 as being the most absorbent. Prolonged use of corticosteroids, which also creates immune phase, but thyroid, heparin, sedatives, and anti-seizure medication can also be factors. So those are your drugs. Low testosterone in men and alcohol. Obviously, men are not as treated or diagnosed as well as women are, because we women focus on it so very much. Basically the remodeling that happens with the osteoblast and osteoclast. Osteoblasts are making, osteoclasts are breaking down. It should happen at an even sedentary rate. So I'm sorry, not sedentary, but equal rate. So that you're not having destroyed bone. In osteoporosis, that's obviously not happening. You're having bone being broken down, reabsorbed into the bloodstream sooner. So that word is very tricky to me, but in the text it says reabsorbed, but reabsorbed into the bloodstream, or broken down otherwise. All right. Your symptoms are a lot of times it's going to happen in your spine, hips, or wrists, back pain, and spontaneous fracture, and kyphosis. Kyphosis is where you're like this, and that's a lot of times related to osteoporosis. All right, so kyphosis. Or a lot of times I think of kings being hunched over, old kings. Anyways. And again, like I said, whites are more at risk for this than Native Americans, Hispanics, or Africans. That's, but bone mineral density test, bone mineral density test. It measures gram per volume of your bone density, and the quantitative ultrasound. So quantitative number ultrasound. And dual energy X-ray absorptiometer. Sounds like I made that up, doesn't it? Which is one of your more common ones, and that's done in your hip, spine, and forearm. So one test does your hip, spine, and forearm, and the other test does your knee, heel, and tibia. And they're going to measure the test in a T-score. -1 or above is normal. Greater than -1 is going to be at risk. If you're at -1 to -1.5, that's osteopenia, which is not quite osteoporosis, but it's penia. It's a smaller version of it, okay? It also can be measured in Z, and Z is going to compare you to not just the average healthy person, but the healthy person, or a person of your age, of your ethnicity. So that's what doctors might order there, and I believe that's 2 for that one. All right. The treatment for osteoporosis or osteopenia is going to be nutrition, obviously increase calcium, and calcium is 1,000 milligrams per day for premenopausal and 1,500 for post. You also want to increase vitamin D, and again specifically vitamin D3 and D2 from 800 to 1,000 units. Let me verify that. Yeah, 800 to 1,000 units. So also, they used to use estrogen to it, but estrogen creates a high risk for breast and ovarian cancer. So tit for tat. Biophosphate inhibits osteoclasts, but unfortunately has this really odd side effect of jaw osteonecrosis, which basically means your jaw is going to die. They don't know why that is. The other drugs that are used to treat osteopenia, osteomyelitis, they pretty much, there's a huge list of it. Salmon calcitonin is one of them, but a lot of the other ones are going to end in ONATE. So that's their suffix. So you have clodronate, again that ATE, and alexstronate, and these are just examples. There's several, and by several I mean like 20 drugs that you can use to help with osteoporosis. And again, in some form or fashion, it's going to prevent osteoclasts, inhibit the class or absorption. So that is chapter 63, or as I was 64 in a nutshell.